I'm Vassilis, I'm the youth coordinator of IFCCA, and I would like also to thank you for your time for being with us. I would encourage you to make any questions to our panelists, and hope you will find our webinar very useful for you, even if you are patients or patient representatives, or if you are clinicians. I will pass the floor to Alexandra Mitria, the IFCCA Youth Group leader, for a quick opening remark.
Hello, everyone. First of all, I want to thank you all for being here and taking the time, to participate in our first webinar as a youth group. As you know, living with IBD is a challenge, and with the help of our healthcare professionals, we try to improve the quality of life of every patient. Of course, this is a very interesting subject for the future mothers who want to have a child, who are also dealing with IBD. So I think everybody will have a lot of questions, and this will be a very interesting topic. I want to thank you for being here again. And I'm so proud to open the webinar sessions with the IFCCA Youth Group. We hope we will have more to come. Let's see how this one goes. And thank you again.
Thanks a lot, Alexandra. And now I'm passing the floor to our moderators of today's webinar, Dr. Giorgos Bamias and Evanthia Zampeli, to begin with the webinar.
Thank you, Rafaela. So, hello, everybody. I want to welcome you in this very important webinar, and I would say that it is also a timely webinar because we're just 5 days after the International Women's Day, which we celebrated very recently. And I think it's very appropriate that we are devoting this first IFCCA webinar to an issue that has mostly, but not exclusively, to do with our female patients with IBD. My name is Giorgos Bamias. I'm a professor of gastroenterology at the University of Athens in Athens, Greece. And I will try to moderate this webinar, but definitely its success, it's completely up to you. The more questions you have, the more comments we have, the more active this webinar will be, then the more successful it's going to be. I am joined today by Evanthia Zampeli, who is also a professor of the University in Athens, and I will pass now the microphone to her to officially start this webinar.
Hi, good evening, everyone. I'm very honored and very happy to be here today. Thank you all for joining. As you heard, my name is Evi Zampeli. I've been working in a hospital for many years now, which is a referral center for pregnancy, and even more so for pregnancy in chronic disease. So I have to say, I dare say, before we start, that my knowledge and my experience regarding pregnancy in chronic disease is, I would say, very, very good, unexpectedly good. And that's, I think that's a very important point I need to start with before even you listen to Mary Tzakri's talk. Now, we prepared a talk that is going to cover all issues regarding reproduction. We have divided the talk in 3 parts according to time, before pregnancy, during pregnancy, and after pregnancy. So we've thought of once each part is complete, then questions will be asked. And this is how it's going to go. Now, let me say one last thing. We are here to answer, to respond to your questions, but we are even more importantly here to listen to your worries, to your thoughts, to any fears you have regarding this issue. Let me say no more, and let me introduce our gynecologist, Vassilis Kanellopoulos, who is also going to say a few words.
Yes, good evening. My name is Dr. Kanellopoulos. I'm an obstetrician specializing in fetal-maternal medicine and high-risk pregnancies. And I'm really glad to take part in this very interesting webinar. Congratulations to the organizers for the idea, and welcome to everybody. I would like to pass a few points in brief from the obstetric point of view. Pregnancy in general in a woman who has any chronic disease is considered high risk in terms that she needs close monitoring and the intensive collaboration with other specialties, in our case, the gastroenterologists. The onset of inflammatory bowel disease is usually during the years of reproductive activity. Therefore, it's quite common to have a young woman with a disease who intends to become pregnant or already is pregnant. We as obstetricians, together with the gastroenterologists, should be in close and frequent contact in order to make decisions together in every step of the way during pregnancy and ideally even preconceptually. In general, a take-home message is that the outcome of pregnancy with the inflammatory bowel disease is good, with no adverse effects regarding the pregnancy if the chronic disease is in remission and the patient is in good status and on a stable treatment. Young age is generally a major positive factor for a healthy pregnancy, and we encourage women with inflammatory bowel disease to communicate with their doctors in order to discuss this issue early in the disease course and to make a plan ideally even before conception. If the disease is controlled and under stable treatment, usually the fertility is not affected, the miscarriage rate is the same, the outcome is good, and as it concerns the mode of delivery, there will always be a discussion about the mode of delivery, and this is an issue that probably needs to be addressed basically in the countries with an increased cesarean section rate, and unfortunately Greece is one of these countries. But in general, what we should be aware of is that in various studies, the authors suggest that the cesarean section should be reserved only for obstetric indications, and the vaginal delivery is generally preferable. I would be happy to discuss this issue further and any other questions that we will have during this webinar. Thank you, and we will be happy to attend the following presentations.
So at this point, let me just raise a couple of housekeeping issues. You can always raise your hand. I would suggest that you do that at the end of each of the three parts of Dr. Tzakri's talk. But you can also write your comments in the chat. So we're going to take a look at them and respond to them at the end of each of the three sessions. Also, let us point out that I was the former president of the Greek Society for the Study of Inflammatory Bowel Disease, and Professor Zampeli is going to be the next president starting from this April. Our society, which is called EOMIFNE, we hope that we are very actively involved in all the issues that have to do with taking care of patients with IBD. And we work always in close collaboration with our Patients Association, and Rafaela has been a very pivotal person in bringing the two societies together and working for the benefit of our patients. So with this, I think we are ready to start the scientific part of our webinar. I would call Dr. Tzakri, who is a consultant gastroenterologist at a tertiary hospital in the metropolitan area of Athens, to start her presentation. Enjoy. Let's all hope that we're going to enjoy this webinar.
So, good evening. Thank you for your kind invitation to this webinar. I'm going to start sharing the presentation now. Rafael, I think.
Yes, you have to stop sharing your whole screen, and Your choice will be to share the window.
The window,
But
that
you have to
can
go
work
to
like
the keynote window. Do you want me to share the presentation and you will say me next slide? But
this window now.
perfect.
So I can start? Can I start?
Yes, you can start. It seems very clear and we see your presentation.
So we're going to talk about IBD in pregnancy. There are a lot of topics and issues that patients are concerned about. And in the first section of the presentation, we're going to talk about fertility, the familiar risk of IBD, and when is the right time to get pregnant. In the second section, we're going to talk about medications during pregnancy, how we treat the flare during pregnancy, and if any surgery is needed, how we assess the IBD disease during pregnancy. And then in the last part, we're going to talk about the mode of delivery, lactation, and any concerns about the child and the infant. So many patients have this fear if they can pass on the disease to their children. So we know there is a familial risk for IBD because genetics generally play an important role in the pathophysiology of the disease. However, there is a slightly higher risk for a child to develop IBD if their parents have IBD. And this risk is higher if the parents, one of the parents have CD compared to UC. The risk of the child to have IBD is 6.2% if parents have UC, while it's a little bit higher if they have CD, like 9.2%. It doesn't matter if the parent is who has the disease is the father or the mother. But we know that if there is another person in the family, first degree family member who have the disease, the risk is higher for the child to develop the disease. But we should bear in mind that the likelihood of having a healthy offspring when one parent suffers from IBD is more than 90%. So this fear, it could be logical, but the data are that people with IBD can have healthy children. Of course, if both parents suffer from IBD, the likelihood of a healthy offspring is above 60%. We know that there are also other risks for IBD in offspring, regardless if the parents have IBD or not. These factors are cesarean delivery, smoking mothers, and antibiotic use during pregnancy. However, they are not the only conditions that can cause IBD, of course. There are also genetic factors and environmental factors, but and if the mother needs to have antibiotics during pregnancy, then we will give them. But it's not the risk a lot higher than the general population if parents have IBD. Another topic is fertility. Many women worry about their fertility, mainly because of the medication they are taking. So let's see the data. The infertility rate when IBD is in remission is around 5 to 14%, as in general population, so it's not decreased. We know that there are some factors like surgery in ulcerative colitis when there has been ileal pouch anal anastomosis. Maybe the fertility is decreased, and mainly active IBD can have a negative impact on fertility. And also there are studies that have shown that there may be a reduced ovarian reserve in some patients with IBD. But regarding the assisted reproductive therapy, the effectiveness is comparable with the general population, and also IBD with pelvic surgery does not affect the effectiveness of ART. So patients with IBD, they can use this way to acquire offspring. Briefly, we know that disease activity like Crohn's disease, when there is salpingitis or pelvic adhesions, can decrease fertility, and also surgery like IPAA, as I said before, it can decrease fertility, and some medications like sulfasalazine can cause fertility problems like reversible oligospermia in men, but it does not affect women's fertility. Another topic we should think about the fertility is that many patients are afraid to have children, as we said before. So voluntary childlessness has been calculated around 17%. And there are some, as we said, some studies that have shown that IPAA surgery affects negatively the fertility. But in recent studies, this result was not replicated. So firm conclusions cannot be made for IPAA. Of course, when laparoscopic approach in any surgery is followed, then we have better results in fertility. And we've talked about sulfasalazine, about infertility in men. So in IBD, healthy pregnancy can be achieved. But when is the right time to do so? We know that in IBD, there is the right time when we would like a pregnancy. And this is when disease activity is controlled, when patient is in remission, ideally for 3 to 6 months prior to conception. And that means that we aim to steroid-free clinical remission, so the patient doesn't need to be on steroids. They have fecal calprotectin less than 100, a normal CRP, and even endoscopic remission is better when we would like to achieve a pregnancy. In order to achieve these goals, we need to optimize therapy. This means that we have to escalate therapy accordingly so that we can keep our patient in remission until the conception is achieved. We always have to talk to our patients and give recommendations about this topic. And we have to insist on controlling disease activity and recommend healthy habits for our patient. Advise them to quit smoking, have the required vaccinations, and of course follow a safe medication regimen which should be continued during pregnancy so that we can maintain remission, as we said. But why we insist so much about the remission? Because we know that pregnancy in remission is considered to be a moderate risk pregnancy. 1/3 of the patients will have a flare if pregnancy is achieved in remission. But if a pregnancy happens during a flare, it is considered an increased risk for the baby and the mother. 2/3 of these patients will continue to have a flare, and 2/3 of them will deteriorate. And if they deteriorate, then an episode of severe flare can happen. And this could lead to 60% of fetal death, which is not a good outcome. So, IBD pregnancies are considered high risk when, as we said, disease activities are controlled. This means that there are complications during a pregnancy, such as gestational diabetes, severe eclampsia and preeclampsia, thromboembolic disease during pregnancy and postpartum, and preterm delivery. And for the fetus and the infant, we may have neonatal ICU admissions, small for gestational age infant or low birth weight, or a low APGAR score. And these outcomes happen when active disease is present. There is no known risk for early childhood malignancy or developmental delay that is related with the medication that the mother may have taken during pregnancy. So even histological inflammation is important. It has been shown that histological inflammation is associated with preterm delivery at a rate of 9.6%, while the percentage of preterm infants is 6.5% when histological inflammation is absent. So this was the first part of our presentation, and we can proceed to any questions for these topics.
Okay, so thank you, Mary, for this first part. I think we can stop here and we can start our discussion. This is the moment that we would like to hear your thoughts. It doesn't have to be a question, it can be a comment, or it can be an experience that you want to share with us, maybe an advice that you have for your fellow patients or even your treating physicians. So I see the first question there. Carmen asks if there is a higher risk for C-section with ulcerative colitis.
Yeah.
Okay, so
mode of delivery. So we'll talk about that, but we can answer also.
Okay, so Mary, why don't you start?
Okay. What I said about the C-section is that in the general population, parents without a history of IBD, if they have a child with a C-section, then it has been shown that it may play a role on the microbiome of the infant, and in the future, the child may acquire the IBD. But it's not the only factor, and it's not a very concerning, let's say, cause of IBD. So this is what I said in the talk about C-section and ulcerative colitis or Crohn's. I don't know.
Okay, Mary, thank you. So I want to couple this question with Alexandra's comment. Who is scared to have a natural, to give a natural birth to her child and prefer to do a C-section? So Alexandra, why would you be scared for that?
I'm ashamed to say it, but you know that lower part of our body changes forever, and I also am afraid of pain. I'm afraid of contractions, and I think that being almost asleep and having a C-section maybe will be more comforting for me. But I am afraid to have a natural birth.
All right. I think now we should call the surgeon. We should call the OBG doctor to help us here. So, Vassilis, should Alexander and any girl with IBD be afraid to have a natural birth?
What I understand, Alexandra, is that your fear is not really related to the disease, but in general, as it concerns
Yes,
the
in general to
mode
the
of delivery.
natural birth, yeah.
And that is very well discussed, and already we have decided in medicine that the normal delivery is always the first option that we have, because it's a natural way of delivery. The complications are definitely lower, and in your case, if in a patient with inflammatory bowel disease, if an abdominal surgery can be avoided, is definitely preferable because of adhesions, because of the risk of inflammation, because we can interfere with the bowel, the way the bowel functions after surgery, and it needs time to recover. And in your case, the time is much more. And also in patients with Crohn's disease, the way the wound develops, the way as we care for the wound we have most of the times problems with the wound closure because of the extra inflammation and everything. So some risks are even higher in patients with chronic diseases and inflammatory bowel disease. So if we have an extra reason in your case to try to avoid an abdominal surgery, and I will have to make sure to you that when the time comes, you will realize that it's something really natural and that has very, very small risks involved. But if we have more questions, we can go into further details.
Oh, okay, thank you. Now it makes much more sense, because I didn't take this into consideration, that it would mess up my gut inside if we do a C-section. But yeah, thank you.
Are you feeling better now, Alexander?
Yes, now I'm feeling actually maybe
She's ready for the delivery.
yeah.
So already our webinar has an effect. Okay.
Yes.
That's why we're here today. Now, let me make a comment regarding ulcerative colitis and the operation that a few patients occasionally need, patients who have ulcerative colitis. And perhaps you have heard about pouch surgery, which is the operation of choice for these patients. Now, if there is ulcerative colitis, there is no reason at all not to go for vaginal delivery. But if pouch surgery is planned, then Christos Veretanos has made the comment, and he's absolutely right. Then there should be a discussion with the gastroenterologist and the surgeon, both specialties, regarding reproduction, because this surgery and any surgery in the pelvic area causes adhesions, and that's the main reason why fertility is affected. So there needs to be a very thorough discussion regarding this issue of reproduction before such an operation is decided upon for a patient. I don't know whether we answered the question, but that's in general one of the indications for a cesarean section in IBD is pouch, the presence of a pouch. That's why this discussion needs to be done, needs to take place before operation. The other indication, Mary is going to talk about this later, is when there is active perianal disease. These two are the indications for cesarean section. If these are not the cases, though, then the woman, unless there is an obstetric indication, should go for vaginal delivery. Now, there are other questions as well, I think.
We have a lot of questions.
Alexander, would you like to make
Yes.
additional
Yes, that's what I asked. So I have history with perianal abscesses and rectovaginal fistulas. In this situation, the C-section is more suitable than the natural birth?
Definitely.
Oh,
Yes.
definitely. Okay.
Clear. That's clear. Yes.
Okay, thank you.
We have a lot of questions. Some of them will be for the second part of Mary's presentation. It's about medication, etc. But we can go.
No, before I think we have again a question that is for Vassilis that says, can a patient who has multiple surgeries can have a normal delivery, or she should go into C-section?
Of course, the answer should be individualized, because we need to know what sort of surgeries are these and in what way they could affect the normal delivery. But general abdominal surgeries will not affect the mode of delivery, and it also makes it higher, more likely to try to avoid another abdominal surgery in case of serious adhesions that might be in the area. So the more surgeries, abdominal surgery someone has, the more preferable way is the vaginal delivery, unless there is some other form of contraindications. And the perineal disease might be what Alexandra said earlier. Perineal disease from the inflammatory bowel disease could be a problem, especially if we have an instrumental delivery and we have to do an episiotomy. But in the hands of somebody who is experienced and knows the anatomy of the area, and we need to know exactly what has happened before and what exactly the problem in the area is, we can try to avoid all these problems. And there's no need to try to go ahead for another surgery just because of the previous history.
Okay, thank you, Vassilis. Now, there are many questions that refer to the other two sessions, but there is one that is with what we're talking at this moment. So, Mary, you did all this nice pre-webinar work. So you should answer to Nada's question, if a patient with a stoma can be pregnant.
Yeah, so I didn't find so much information about it, but in general, it's not a contraindication. So patient with a stoma, they can have a pregnancy. It could be a healthy one, and also they could have also vaginal delivery. It's not a contraindication, the stoma. So yes, I think this is the answer. It's not a contraindication for pregnancy.
Yes. Let me emphasize that it's definitely not a contraindication once the disease is in remission, and it usually is when there is a stoma. So on the contrary, Nadia, yes, should go for becoming pregnant. The only thing that needs monitoring is to be in contact with perhaps the stoma nurse or someone. Perhaps the stoma will need further care during the pregnancy because of distension of the abdomen, but that's about it. There's no reason for Nadia or for anyone who has a stoma not to attempt pregnancy.
And also, I read also somewhere that sometimes before the pouch surgery, we may have a stoma. And if they plan to have a pregnancy, then have the pregnancy and do the anastomosis after.
Later.
That's an excellent remark, Mary, yes.
Yeah, so that we don't have the fertility issues with the anastomosis and the pouch and all that. This is something that we can suggest to the patient if they plan pregnancy.
So thank you, ma'am. So you can see now that this is a theme that will come over and over during our webinar, that everything is about planning. Everything is about being ahead of the events, work closely with your team, with your doctor, with your nurse, with your dietitian and all the group with your OBG doctor. Plan on time, plan ahead of time, and everything will work out nicely at the end. So I think we should move to the next part of the presentation. Don't worry about the questions. We're going to answer all of them, but because they relate to the second part, let us hear first what Dr. Tzakri has to say, and then we're going to have a nice discussion, because it seems that you are very interested in the phase of pregnancy itself and the medications and all these things. So, Mary.
So I will continue to share my screen. If you can see it.
Not yet. Now we can see it.
Okay. So now we're going to talk about medication. That I know many of you are concerned, and not only patients, also doctors have their concerns about the medication we use in IBD, and if they are safe for the baby and the pregnancy. So what medications are safe during pregnancy? We know that there are potentially teratogenic medications, and these are methotrexate, which should be discontinued at least 1 to 3 months, but it's better 3 months prior to conception. And also JAK inhibitors like tofacitinib, upadacitinib, and S1P modulators are also contraindicated during pregnancy. This is a table where you can see at a glance what medications are considered safe. And let me tell you that the most medication we use during pregnancy or not during pregnancy are safe. Only methotrexate, JAK inhibitors, and S1P modulators are not safe for pregnancy. The rest, like 5-AZA, thiopurines, azathioprine, corticosteroids if we need them, and biologics like anti-TNF, biosimilars, vedolizumab, anti-interleukin 23, which are newer medications. They are considered safe for the preconception period, during pregnancy, and breastfeeding. We talked about 5-AZA, sulfasalazine is also safe. Corticosteroids are safe to treat a flare during pregnancy, but we would rather use them only when it is necessary, because there are studies that have shown some complications for the pregnancy and delivery and the baby. But if we need them, we will use them because of the quick response they have in IBD flare, and because it's a very easy way to have a remission when there is a flare. If a patient was on thiopurines and they are in remission at the beginning of the pregnancy, we will keep it during the pregnancy. We don't have to stop azathioprine, for example. But as we said, methotrexate is associated with abnormalities in the face, in muscles, in skeleton, the central and cardiac systems of the infant, so it's contraindicated. Anti-TNF with azathioprine in combination therapy is also safe during pregnancy. And as we said, vedolizumab and ustekinumab are safe, and all the biosimilars. For anti-interleukin 23, like risankizumab, mirikizumab, or guselkumab, the data is more limited, but we anticipate that the results will be the same as for ustekinumab, so they are considered safe. And the rest is the JAK1 inhibitors, we said, and the S1P modulators. which are contraindicated. And if a patient is on this medication and they plan a pregnancy, they should stop tofacitinib for at least 4 weeks before pregnancy, ozanimod for 3 months, and etrasimod for a few weeks. So during pregnancy, we need to assess the IBD. How can we do that? So some lab tests like CRP and hemoglobin are affected by pregnancy. But fecal calprotectin is a very good indicator of disease activity during pregnancy. And also intestinal ultrasound is very safe when it is available, and it's very useful for the disease activity, especially in the first and second trimester. In the third trimester, sometimes it would be hard to visualize the terminal ileum and the sigmoid because of the baby. The CT is relatively safe, and we should not be afraid to use the CT scan if we need to exclude a complication of the disease, like an abscess or a perforation. So it's relatively safe. An MRI without gadolinium, because of its toxicity to the fetus, it could be used. So here we can see that the bowel wall thickness is well correlated with adverse events during pregnancy, like preterm delivery, preeclampsia, and neonatal intensive care unit admission. So it's very useful, the IUS during pregnancy, to predict the outcomes of the pregnancy. So what if we need the endoscopy? Endoscopy is considered to be a low-risk procedure in all 3 trimesters, but we will prefer to perform it only if it will change the management of the patient. Most of the time, we use a flexible sigmoidoscopy, which is well tolerated by the patients, and we don't have to use sedation, because sometimes sedation medication is a problem during pregnancy. If we need to do a full colonoscopy, then fetal monitoring is recommended, and the most common sedation medication that we use is propofol. So in case of a flare, what is next? What are we going to do during pregnancy? We'll try to do what we do as if there was no pregnancy. That means that we will start or optimize IBD therapies that the patient was taking, or start new medications, except for thiopurines, methotrexate, JAK inhibitors, and S1P modulators. Thiopurines are not preferred to be started during pregnancy because there is a risk of the intrahepatic cholestasis, and also sometimes the liver metabolism is altered during pregnancy. So we would avoid the thiopurines so that we can avoid the hepatotoxicity they may cause. Low-risk antibiotics, they can be used during pregnancy. For cyclosporin and tacrolimus, the data are limited, but they are considered safe. And corticosteroids. So corticosteroids are commonly used for a flare, but there have been studies that they have associated, the corticosteroid use has been associated with preterm birth, with small for gestational age infant, a low birth weight, NICU admissions, and serious infections for infants. So we could say that corticosteroids are safer in the first trimester, although still in the first trimester, sometimes corticosteroids are associated with facial abnormalities. So it's a really good medication, but we would rather not use it during pregnancy. But if there is a flare, and it's very important to control the disease, because the complications of the active disease, as we said, they are harder to manage. We will use corticosteroids to control the disease. So in this table, we can see briefly the most commonly used medications during pregnancy for a flare. They are corticosteroids or anti-TNFs as well. We would prefer sometimes anti-TNFs because of the rapid onset of action. They have a quick response for the patient, and also they are safe. We also can use 5-ASA, and you can see as the gestational age gets higher, let's say we are at the 37 weeks of the pregnancy, we can use delivery instead of medications. So as you saw before, 5-ASA steroids and TNFs, they are very safe during pregnancy for a flare. But also the ustekinumab and vedolizumab, they are safe and good treatments for a flare. But sometimes patients do not respond to the therapy, or they may have a complication and they will need a surgery. If the patient needs a surgery, this should be done when it is required. It's not a decision that is based on the trimester of the pregnancy. If patient has an abscess, a perforation, or an uncontrolled bleeding, they may need a surgery, and we will have to take the decision to proceed to surgery. Of course, surgery during pregnancy, it can have complications, and these are small for gestational age infant, a preterm birth, and even a miscarriage. So this was the second part, and we can proceed to your questions for these topics.
Okay, thank you, Mary. Let me just sum up because I think a few of the answers are going to be answered. Now, first of all, most of the medications, almost all medications that are in use at the moment are safe during pregnancy. The only medications that we're not permitted, we're not allowed to use is methotrexate and the new small molecules. All other medications are safe, and we know that. We have an experience of about 20 years with the anti-TNFs especially. That's one thing. The second thing I would like to say is that pregnancy should be planned and remission should be confirmed before before becoming pregnant. And that's something that should be discussed in advance. In advance means early on, once the disease is diagnosed, and then once the disease is in remission. And when we say remission, Mary has emphasized that remission means deep remission, like we call it. It means that the patient is well, but also there's no ulcers, there's no inflammation in the bowels in the endoscopy. It needs to be confirmed and very, very strong. There needs to be strong remission. Third thing, during pregnancy, we do not discontinue the medications that have secured remission for the mother. We do not stop them, we do not change them unless there is a reason. And usually there's no reason to do that. because once the pregnancy starts with the disease in remission, remission will terminate pregnancy. It means, I think Mary has already shown that diagram, that 2/3 of the patients who are when their pregnancy in remission will remain in remission. That's why we aim for remission at the beginning of pregnancy. So there won't be any reason for changing, switching, stopping medications unless of the unfortunate occurrence of a flare. If there is a flare, and with this I will stop. If there is a flare, what do? We need to instantly and effectively control inflammation. How do we do that? We mostly use steroids, yes, with all these considerations Mary already mentioned, but we do that because not controlling the inflammation is what causes adverse events. That's why we need steroids, we use steroids and anti-TNFs. These are the two, let's say, groups of medications that we use in order to control inflammation if the flare occurs during pregnancy. Now, with those comments, let me go back to your questions, because there's a lot of questions regarding medication, and we expected that. Mary, we'll start with you. The first, yes, Ines is asking about whether she can become pregnant whilst the disease is active at the moment. And her boyfriend also has, no, her boyfriend does not. Yes, they both have Crohn's, but her Crohn's is active at the moment. Is it safe to get pregnant?
So, as I mentioned a lot of times before, it's better to try to get the disease under control. We need, if it's very good that you ask, so that you can plan. We need to do a plan for pregnancy, and then that's why I emphasize the need for controlling the disease. So it's better for you and your future baby to be in remission before you start this procedure. So I think it would not be a good idea to get pregnant now that your disease is not controlled.
The question was about her boyfriend being active at the moment.
Okay.
So, yes.
Boyfriend. Well, I think we don't have this issue about the boyfriend unless they are on medication that can cause fertility problems. But if they don't have erectile dysfunctions, let's say fertility problems due to surgery, for the boyfriend, I mean, then I didn't find any information about the active disease of the father that could have a negative impact on pregnancy, because it's most for the mother that we need
definitely the activity of the disease in the boyfriend does not affect the pregnancy. Just one asterisk there: if your boyfriend is on methotrexate, that he should stop taking methotrexate for some months before trying to get pregnant. So let's move on with other questions. Okay, I'm thinking. Okay, so until we search the questions, does any of our patients want to come up and express their concerns about medications and pregnancy, their fears? Would they hesitate? Would they prefer not to take any medication during pregnancy? Any bad experiences? Does anybody want to speak?
We don't have anybody with a raised hand, but as I see from the questions, most of them have already answered by Mary's presentation. But we have one about anemia from Philippa.
Yes.
Yeah, I can take that. So, Philippa, anemia should be corrected when you have IBD, irrespectively of whether you're trying to get pregnant or being pregnant. So yes, anemia should be corrected. On the other hand, anemia is a very common event during a pregnancy, and you should work very closely with your doctors to correct that according to the guidelines. So it is not a major or a particular concern, but it should be corrected nonetheless. So another question is, Dilara asks a very important question. Mary, already you alluded to that, but you should repeat your answer and clarify more. A patient is in remission, gets pregnant, everything goes well until there comes a flare of the disease in the middle of the pregnancy. So what is your advice to this patient? How would you treat her flare within the pregnancy period? Would you do anything different?
I would do exactly what I would do if the patient was not pregnant. Let's say firstly, we need to assess the probability of an infection and treat an infection if there is one, because commonly an infection can be a cause of a flare. But if we rule this out and we talk about the flare of the disease, we need to control it, and we need to control it fast. So probably we will give corticosteroids and then see what therapy was the patient before. Are we going to escalate this therapy or change to another biologic, or what? We will see the options we have, so that we will induce remission with corticosteroids. And then we're going to find a medication to maintain this remission. Sometimes we do that with anti-TNFs because we know this is safe during pregnancy. So we can start an anti-TNF regimen during pregnancy to control the flare and maintain remission afterwards.
So, Mary, you already said that you wish to exclude some infections that may cause this flare of the disease. But we know that to exclude some of these infections, we should perform endoscopy, let's say for CMV. So what is your advice? Should we hesitate? Should we be afraid of doing endoscopy during pregnancy? What do the guidelines say?
It's a low-risk procedure, so we're going to perform endoscopy if we would like to rule out CMV infection. We will not hesitate to do so. Most of the time we do flexible sigmoidoscopies, which are safe for the patient and they are very well tolerated. So we will not be afraid to do that if we need to do that. If patient is not responsive to corticosteroids, let's say.
Now, there's a couple of questions regarding pregnancy in short bowel and pregnancy in somebody who has an enterocutaneous fistula. With respect to the second, probably I gather an operation has been performed and probably this fistula is post-operative. If either this or it's a spontaneous, let's say, fistula are the cases, I think in both cases, due to the fact that there is inflammation, there be some limitation in terms of fertility. But other than that, I wouldn't think that there would be any problem in carrying a baby. Now, in regards to short bowel, I think a general comment is that it will depend on whether there is and what grade of liver disease there is along with the short bowel. It will depend on that. And if we're talking about transplantation, which means that, because this is the comment that our friend, our patient has made, if we're talking about transplantation, it usually means that there is indeed liver disease. So medications perhaps would be a problem again in terms of getting pregnant, not so much in terms of carrying out a safe pregnancy. But that's a very special issue. I wanted to make these comments, and I know it's a difficult situation. But still, I think we should be optimistic even for these difficult cases, as long as doctors cooperate for the care of our patients. Now.
So let me check if there are more questions.
Yes.
So maybe we should talk about preeclampsia in the third part, or should we ask our OBG specialist right now about that?
No, I don't have that much information about it.
So Vassilis,
high-risk pregnancy as a complication of the pregnancy due to activity.
All right. So I want to ask Vassilis a question regarding the prophylactic use of aspirin during pregnancy. Our guidelines suggest, although they mention that there is low evidence for that, that our patients should be considered high risk for preeclampsia. It should be treated with aspirin starting from week 12 to 16, and then stopping it around the 37-week due to increased risk of bleeding. And they say that if the woman is a high-risk group for preeclampsia, we should be more careful there. Would you please give us some advice there? Who is in high risk for preeclampsia? What should we do? What should we put attention into? Would you help us a little bit there?
Yes, of course. There doesn't seem to be an increased risk for preeclampsia in patients with inflammatory bowel disease. There's always a screening test that we do in the beginning of the first, at the end of the first trimester, which involves the nuchal translucency examination, and then together with some blood tests that we do measuring the beta-HCG and the placental growth factor, we identify the individual risk for preeclampsia early in the pregnancy. And at least to our knowledge, we don't include patients with inflammatory bowel disease to the group of increased possibility of preeclampsia. Therefore, we would treat the patient as any other patient, and if we see an increased risk at the end of the first trimester, then the gold standard medication in order to try to prevent preeclampsia is the use of aspirin in a dose of between 80 and 160 milligrams until the 36th week of the pregnancy, but not necessarily to all of your patients.
Okay. You are muted.
Sorry about that. Thank you, Vassilis. I don't see any hands raised.
We'll discuss about vaccinations later on.
So if there is no, Alexandra wants to say something.
Yes.
Okay.
Yes. What about the breastfeeding? Because
This is in the third part, Alexandra.
okay.
Would you be patient for for a little bit more? Okay. So Mary, again, back to you for the third part of your presentation. Okay.
Yes, and the last one. So now we're going to talk about the mode of delivery in patients with IBD. As as our obstetrician said, the mode of delivery should be an individualized approach in IBD. There are no firm indications for C-section or vaginal delivery in patients with IBD, except perianal Crohn's disease. So when perianal Crohn's disease is active, maybe it's logical more rational to prefer a C-section. When perianal disease is inactive, we should consider about the severity of the prior perianal disease. In this case, we could do vaginal delivery. But when there is rectovaginal fistula, which is a complication of perianal Crohn's disease, it would be better to plan a C-section. So we should approach every patient differently and individualize the mode of delivery. There are conflicted data as well for the surgery of IPAA. So some studies showed that the vaginal delivery in patients who have had an IPAA before negatively impacts the pouch function. The quality of their life could be worse after vaginal delivery. There may be some sphincter defects after vaginal delivery, or there may be some trauma during vaginal delivery. So it would be better to plan a C-section after this kind of surgery. Otherwise, there are no contraindications for a vaginal birth in a patient with IBD. This is a schema, a picture that shows how is the pouch and how is the baby. And you could see that it could be some trauma during vaginal delivery in the area. So C-section could be better when there is a J pouch. So as for breastfeeding, regarding breastfeeding, it should be encouraged, of course. There is no increased risk of exacerbation or no increased risk of infection. Mothers with IBD may breastfeed even if they take medication for their disease, like 5-ASA, thiopurines, even corticosteroids, anti-TNFs, vedolizumab, anti-interleukin-23, and biosimilars. Of course, they should not breastfeed if they are again on methotrexate or S1P receptor modulators or JAK inhibitors. Concerning antibiotics, there's been a lot of studies and information about them. Metronidazole, ciprofloxacin, and amoxicillin, they are considered low risk. So the patient, the mother, can have them if she needs them, and she can also breastfeed. For ciprofloxacin, there were studies that in the past that showed that it may be associated with arthropathies of the child, but recent studies have not shown a high risk for that. So we still use ciprofloxacin during breastfeeding. For metronidazole, there are some cases that has shown they have demonstrated that metronidazole can cause diarrhea in the infant and also candidiasis. So if the mother needs a course of metronidazole for 1 week, let's say, she can have it, but we would recommend to do the breastfeeding before taking the medication, so that we eliminate the likelihood of the child to have diarrhea or candidiasis. And of course, we will monitor the infant. Are there any outcomes of children exposed to biologics during pregnancy? There are good news about that. There is no increased risk for autism, emotional symptoms, neurodevelopmental disorders, metabolic diseases, or serious infections for the infant if they have been exposed mainly to anti-TNFs or other medications during pregnancy. And now turning to vaccination of the child, there are some newer guidelines now. We all agree that inactive vaccines should be provided on schedule. There are some concerns about the live vaccinations, like live rotavirus vaccine. We used to say that live rotavirus vaccine should be done after 12 months of age in the infant, but now we say that it can be provided at 6 months as the rest of the children. But there is a concern for the live BCG vaccine that should be avoided in the first 6 months. Live vaccines can be given while on breastfeeding. These are vaccines that are non-live vaccines, and they should be given on schedule. And as we said, rotavirus live vaccine can be given between 2 and 6 months old for infants that were exposed to biologics in utero. And the BCG is safer after 6 months. If BCG vaccine needs to be given earlier because of epidemiological reasons, then we should think that we should take into consideration that and avoid the anti-TNF or the biologic during the 3rd trimester, so that the infant can have the BCG vaccine earlier in life. But this is something that we can plan this. And this is a concern because TB infection and even deaths have been recorded with the BCG vaccine if it is given before 6 months and the baby had an exposure in the 3rd trimester of anti-TNF. Any other live vaccine should not be withheld in breastfeeding infants. So now I'm going to present some data from our Greek registry for IBD and pregnancy. It's a study with, it's a multicentral, retrospective and prospective study of pregnancy in IBD patients from 22 IBD centers in Greece. We had 314 patients, 44% had CD and 46 had ulcerative colitis. And here we can see the medications the patient were on at the beginning of the pregnancy. We can see that most of them were on 5-AZA and also thiopurines, and a lot of them were on infliximab or adalimumab. 22% had a flare during pregnancy. At the gestational age, around 18 weeks. They were treated with steroids, most of them, and then 5-AZA, admission to hospital, and also anti-TNFs. And the results were good. The results are very encouraging. We had a healthy infant in 97%, and 74% of the patients managed to breastfeed. Of course, the C-section rate was high enough, like 67%, but preterm births and neonatal infections, which are considered to be complications, they were relatively low, 16% and around 6%. So with all this, if we keep in mind, we know that active IBD is a risk factor for pregnant women and can pose risks for the mother and the fetus. But if doctors, the gastroenterologist and the obstetrician, we work together and we optimize therapy, then we can have a healthy pregnancy and a healthy baby in the end. That's all for me.
Very good. Very good, Mary. Thank you. Now, there is a question, and we'd like for you to repeat what you said about vaccinations of the infant and whether are affected by the fact that the infant may be exposed to biologics during pregnancy.
So, if the infant is exposed during the third trimester, the only vaccination that we will avoid in the first 6 months is the BCG vaccine. The rest are considered relatively safe and they can be given, and also the response of the infant is considered to be good. They have a good response to vaccines, although they have been exposed to biologics in the third trimester. That's a change in the recent guidelines, because I think in the past we were more afraid of the live vaccines during the first 6 months.
Yes, that's true. And also the guidelines have changed in terms of when and if we discontinue biologics at the third trimester. They used to recommend stopping, withholding biologics during the last 4 weeks, which is something that changed, and it's very reassuring, because it means that even if there is exposure to biologics during the third trimester, this is not associated with any adverse problems, response to vaccinations, infections, hospitalizations for the infant. So it's even more reassuring that the medications we're using during pregnancy are very, very safe. We have data for almost 10 years now regarding all potential problems that the exposure to biologics could cause to the infants, and the results are very, very much encouraging.
So there are a couple of more questions for the third part. Sorry. So Alexandra asked if there is any evidence that breastfeeding triggers a flare of the disease. Definitely not. Mothers with IBD should breastfeed, because this is a very good thing for the baby. There is no danger to get a flare because of that. We answered about the vaccinations. Okay, so Nada asks if she can do some kind of test to predict if the baby will have IBD. No, Nada, there is no such a test right now. But I take this opportunity to say that the probability of having a healthy baby, rather not a healthy, a baby that doesn't have IBD, is more than 90%. So I don't think this is something that you should worry about. In a more general view of the pregnancy and IBD, I would say that there are, as it happens in life, there are things that we can do something about it, things that we cannot do something about it. So yes, there is a slightly increased risk for a baby of a parent with IBD to also have IBD, but this risk is very minimal. So it shouldn't be a major concern. What should be of concern is to have a planned pregnancy, to follow the guidelines, to follow the steps, to work closely with your doctors, and then in more than 90% of cases, the pregnancy goes as it would if the parent didn't have IBD. So that is the point that I want to make there. But no, there is no test that predicts if a baby will develop IBD later on in life.
Let us move on with another very interesting question by Katerina regarding IVF, regarding assisted reproduction. She's asking about it. I want to say something before Vassilis tells us his opinion regarding this very sensitive issue as well. Now, the data show that the chance of success with IVF in patients with IBD is comparable to the general population. But there are problems, technical problems with this, the planning of these trials regarding to which is the outcome, as we call it. So there are problems in evaluating the results of these trials, but in general, the results are comparable to the general population. And no, in general, we do not think, there's no data that the medications, exogenous steroids and other medications that are being offered through this procedure cause flare of the disease. And Katarina, I want to say that we cannot prove that the flare of the disease, for the flare of the disease, were the medications to blame. But okay, I'm open to this is open for discussion. Now we know that it is safe. We know that it is comparably, similarly effective with the general population, and we know that it is a method that we encourage in women who need to do that in order to become pregnant. Now, Vassilis, if you want to add something about assisted reproduction in patients with chronic problems, diseases.
Yes, of course. Thank you. There does not be any similar differences in patients with IBD compared to the population that doesn't have the success. The IVF success rates are similar, and definitely when the disease is well controlled and in remission, pregnancy and live birth rates are generally comparable to the general population. Everybody understands that in the presence of an inflammation in the area, the tubes could be affected, the ovaries could be affected, the metabolism changes a little bit, and the ovarian reserve could be slightly different. But in order to answer Katerina's question, especially because in IVF, when we manage to retrieve the eggs and we manage to have a fresh embryo, we usually freeze them and we transfer them at a later stage. So this is an extreme advantage because we can wait for the remission and better control the disease and try to transfer the embryo at that stage. Of course, IVF does not guarantee the result, and the one unsuccessful attempt doesn't mean that the reason behind it is the irritable bowel, the inflammatory bowel disease. So being in close contact with the gastroenterologist, the success, achieve a remission of the disease, and then transfer the embryo at that stage could increase the chances of a future pregnancy.
So thank you, Vassili. We don't see any more questions right now, so I think at this point, let's say the medical team of the webinar wants to thank you all for your participation. It was very nice to have this interaction with you. I want to thank Mary Tzakri for preparing this excellent presentation and answering to many of the questions that we all have during our clinical practices. I want to thank Vassilis for being here with us and helping us with his expertise in the OBG field. And also I want to thank my co-moderator, Evanthia Zampeli, for helping the webinar to move along. And now it is time to give back the microphone to Rafaela and the patients, because everything is done for the patients. And for us, from all of us, thank you very much for your participation again.
I want to thank all of our doctors, the speakers, the moderators for their participation in our webinar. And at this point, I would like to give the speech to Magdalena. Magdalena is an IBD patient and also a board member at IFCCA, who has a personal experience with IBD and pregnancy, and she will share her story. Magdalena, we are really sorry about this little bit delay, but the floor is yours now.
Good evening, everyone. I hope you hear me. I'm sorry if you hear some strange noises, but my daughter just is eating dinner. So if you heard something strange, I'm sorry. My name is Magdalena Sajak-Szczerba. I am board member of IFCCA. I gave birth to my daughter last year. I'm not sure whether, or I hope you had an opportunity to read the guidebook that was made or prepared by the Slovenian Association. It is written there that IBD does not affect the fertility on its own, but the surgeries performed within the abdominal cavity may, because of the adhesions that form after the operation. And this is the situation that I had. I was diagnosed with IBD Crohn's disease in 2002, and in 2011 I had a bowel surgery. Me and my husband were trying for a long time to have a child, and it was unknown why there is no such possibility. It turned out that I have lots of adhesions, post-operative adhesions in my abdominal that had to be removed laparoscopically. And after that, I managed to get pregnant. My pregnancy went without any complications. It was a risky pregnancy, but due to my age. At the beginning of my pregnancy, I visited my gastroenterologist. He prescribed me medication for constipation because it was the problem that I had. And he also advised me that in case of worsening of my disease, I should visit hospital, the pregnancy pathology department. Throughout the pregnancy, I continued to take all the medicaments. I also, at the beginning of the pregnancy, I also had a blood test performed. Amongst others, I had ferritin and iron levels checked. I had very high reserves of those, but despite this, in the second trimester, I had anemia that was treated with supplementation of iron in tablets. I tried to give birth, to deliver vaginally, but due to the lack of progress in the childbirth, it ended up with cesarean section. I was in remission throughout the whole pregnancy. I'm breastfeeding right now. She also eats normal food, but I'm still breastfeeding. And I believe I'm still in the remission because I hope so, because sometimes I feel my bowels. My daughter, I'm sorry, my daughter is totally healthy and everything went without any problems. And that's all from me.
Thanks a lot, Magdalena. It's very, very useful to hear from patients real stories, even if they are success stories or not, it doesn't matter. We are very happy that your story was a success story at all. In this point, I would like to thank all of you for the participation during the whole webinar. The interest and the engagement was really strong, so we know that you need more information and you need more actions on this topic, and it's a promise together with our doctors, both the panelists and the moderators, that we continue to collaborate on this topic, and we will soon call you in our youth group to discuss our further steps and our future initiatives in order to give young patients living with IBD proper information about IBD and pregnancy or making family if they're boys. And that's from my side. Hope you enjoy our webinar and you found it useful. We will upload it in our social media channels after some days. It was recorded. And I want to say once again a big thanks to Mary Tzakri, Vassilis Kanellopoulos, Giorgos, Bamias, Evanthia, Zampeli, and the whole EOM-IFNE for this collaboration for this webinar. I encourage you also to send us, if you have any questions that are not answered during the webinar, I encourage you to write to my email the questions and I will pass them to our speakers and you will receive an answer. Thank you very much. Have a good night.
Thank you. Thank you. Bye-bye.
Thank you. Thank you.
Bye.